So with gastroparesis, have any of you, or can it be used, that naltrexone? And Dr. McCallum, I'm going to address that to you.
Well, I think as I said in my talk, we use it in patients who are taking narcotics, probably beyond tramadol, but one could even invoke tramadol. So we use Relistor typically, either orally or subcutaneously, once a day in patients taking narcotics on the basis that whether it's today or tomorrow, they're going to have trouble. And naltrexone alone really has no great credentials. Naltrexone in you and I would do very little. We're talking about giving it in patients who are taking chronic narcotics.
Thank you for the answer. Dr. Flores, welcome back. We have a question for you. Is there a recommended treatment for a 13-year-old boy with Ehlers-Danlos syndrome, hypoglycemia, and gastroparesis?
Obviously, like Dr. McCallum has written, and we have similar experience with this combination of POTS, hypermobility, and Ehlers-Danlos. I think you have to regulate the gastric emptying. The gastric emptying is, we still, and as I say, the criteria we use here in children's is the 10% retention more than 4 hours. Yeah, we will treat that patient either with any type of agent, a prokinetic agent, and we use more and more now intrapyloric Botox, and we'll be interested to hear what the panel discusses that, because it has been very controversial. I think they're the only 2 papers, 22 patients, 30 patients with Botox, and that has been used now by the insurance companies not to approve Botox at all, So I will say that's the patient that needs to be treated. Yeah, I mean, definitely 30-year-old, and it's not uncommon. We'll see also refractory intractable constipation in some of these Ehlers-Danlos patients as well. Tough patients to treat. I think I would like to hear the opinions of that, but the nausea is sort of the most important symptom in these patients. So we usually treat them for prokinetic agents. Lately, we've been using Motegrity in combination with intrapyloric Botox in those adolescents. With, again, open label, no double-blind controlled studies.
Well, I think
Oh, go ahead, I'm sorry.
not a bad approach, Dr. Flores, but I don't think these days you can get away with ad-lib Botox. I think those days are gone. I think you'd have to do a endoflip first, endoflip technique, endoscopic procedure with an endoflip measurement to see if the pylorus is worthy, just like we do with achalasia. We do a pre-dilation or a pre-treatment endoflip measurement, and then if the criteria, the diameter, and the compliance characteristics are appropriate, there may be discussion about a therapeutic step in the pylorus, but I think the days of ad-lib Botox are gone.
And the problem with the endoflip, but we do it in the older kids. A 3-4-year-old kid, the probe is too big to do an endoflip. So I don't think we can rely on that. We do it in achalasia, and we do it also in adolescents, older patients. But not everybody has the endoflip available. That's another problem.
Well, until you do, I think you use more traditional therapies. But the Botox data, except in patients who have had a vagotomy, where you've had a fundoplication, and there's a clear circumstantial time chronology relationship with the onset of symptoms of gastroparesis. There is some forgiveness for just going straight to Botox. But I think without that, I think traditional prokinetics, adiametics are where we are right now. And there's evidence that, Botox treatment may later on interfere with the decision-making regarding GPOM and relating pyloroplasty if it's needed by the surgeon. So it leaves scars, and it leaves potentially negative fibrosis potentially. So, and you don't know how deep you're going. The needle could be anywhere from muscularis propria to the peritoneum. Yeah, I think you really can't do that without more scientific evidence.
Yeah, the only thing, again, different population, pediatrics and adult medicine. There is a paper just published in a Journal of Pediatrics, our experience here with botulinum toxins in feeding difficulties in young children. These are kids that had failed eating gastrojejunal tubes. And we review, in that case, we were 85 patients and they have 118 injections. And we were able to move patients from the gastrojejunal tube, which is difficult in pediatric population because those patients require constant infusions. And that paper was very suggestive. I agree with you, that we need to have more scientific good evidence. But in some patients like that they're dependent of 24 hours infusions, and we can convert them at least to bolus feedings with a G tube. I think we have some data that is already published by Rosen and Hirsch in our unit here with good results. So different population, adults and kids.
Well, I prefer to use a feeding J. I wouldn't rely on bolus feedings. If it's that bad, I'd use a feeding J. I don't trust bolus peg tube feedings. Those days are not. They're gone as well. They're gone as well.
You're talking about GJ tube, or you're talking about this?
No, I'm talking about a surgical J.
Yeah, it's a little too aggressive for children.
That's not aggressive because pages are just the beginning of a series of negative events. Children vomit the tube back. You're never sure where it is. And the wound is always an issue with acid coming out and all sorts of things. And then when people start to vent through the other tube.
I don't know what, are you referring to?
Venting is very negative. Venting is very negative.
Are you talking about a GJ or a plain G? I agree with you with the GJ. That's a could be a nightmare, because the bile acid is spillage.
The benefit of the J is you can take a biopsy of the stomach. Surgeons do it laparoscopically while you're there. You can sneak up and take a divot of stomach, and you can actually look at the smooth muscle and tell the mother that, although it's a good story, your gastric smooth muscle of the child is normal. That's a very nice bonus to have, that the gastric smooth muscle is normal in myenteric plexus, ganglia, and ICC. You can get that by a surgical J, and that's a very nice.
I don't disagree with that, but I don't think I will go to a J tube as a preliminary. A lot of this, remember, pediatric.
Not the first step, but if you're getting towards Botox, it's not the first step. If you're down the road to Botox, the child has failed standard therapy.
So we have so many questions. I'm going to go on to the next one, and this is for Dr. Abell. A lot of patients don't feel like their pain is addressed, and in the survey, it wasn't specifically for pain, but can you explain a little bit more about that?
Sure. So is the question about pain or about being addressed, or
pain?
Well, the mechanisms are unfortunately not well known, although our GPR-CRC has just recently shown what's been observed for a long time, that people with gastroparesis, particularly apathic, have peripheral nerve abnormalities, sensory abnormalities. So the thought is that that's certainly part of pain, but there are other reasons, the distension, for example, and then the full thickness biopsies that Dr. McCallum was talking about are, I think, very important for trying to determine anatomic causes for pain. There are also the autonomic nervous systems involved. So there may be circulating autoantibodies against nerve and muscle that they play a role. So it's complex. And we all realize that we don't do a good job of treating it. In our center, we have almost a hotline to the pain management people to try to help us, which is over half our patients get seen by pain management. And we use people that are fairly conservative, trying not to use narcotics, trying to use alternative therapies. But it's a tough problem, and we wish we had some more answers.
Yeah, one thing worth thinking about is this stuff that they started at Cedars-Sinai, and this is the virtual reality stuff. We just did one a minute ago. It wasn't just for pain, but it started there for pain. Patients who could not get out of the hospital on different kinds of pain protocols, often intravenous, fentanyl, whatever. So I don't think it's it's any guarantee, but you go through these sessions. You can't take the machine home unless you buy it, but we sort of give it to them 3 times a week, and they come in and go on rainforests, go to deserted islands, swim with porpoises. They do all sorts of things, and the Cedars-Sinai guys, they claim that they've been able to taper and reduce pain meds and stop them. I do it more for nausea and vomiting and rumination syndrome and other things besides pain. But virtual reality is going to be part of our repertoire, and it does have its proponents. There are some people that have good data based on that.
That's very encouraging. I'm going to throw this one out to anyone who would like to answer. So many long-term HPN patients are receiving Benadryl and Phenergan chronically. Does this contribute to further motility disorders and loss of function?
Tommy, you've had a lot of experience with TPN. Do you have any thoughts about that?
Okay, so the question is about Benadryl and Phenergan use?
Yes.
We're not aware of it being a problem like narcotics in terms of a problem for motility. There are always concerns about any of those drugs in terms of things like cardiac function. There's concerns about QT intervals on EKG and the sedation problems. People probably do get some tolerance, but not classic tolerance like you do for medicines that cause addiction. They're much less than ideal, but sometimes it's all we have. And so we generally don't restrict that. I don't, particularly orally, I don't think they're especially dangerous drugs, but people do have to be careful. And Aylin, you may have some comments about that with Phenergan, Benadryl.
In the short term, maybe you can get a little more constipation from those medicines, but I agree. I don't think that they would cause chronic or irreversible. It'd be more just from the acute medication.
And at least in the pediatric population, we had no problem using those drugs.
Thank you. Somebody wrote, let me just look. Why would venting be negative when it's helpful in mitigating the amount of vomiting bile? Anyone who would like to answer that?
I love to see that Dr. McCallum thinks, because many years ago, 25 years ago, he told me, Alex, don't put G-tubes in those patients. The stomach gets lazy and that doesn't work anymore. And I know something, I think he's right about that. I'd like to hear his vision now, but I think that's a terrible indication to vent the stomach, or the exclusive reason. I'm not talking about just to do something else with the stomach. I think that I've seen some problems with that. I don't know what Richard thinks about, but it's not an indication for me to put a hole in the stomach.
Well, we think venting can hide things, okay? The most epidemic condition right now in GI, motility, is a condition called rumination syndrome. It's epidemic. It's epidemic. I see one every day. I just saw one now. It's epidemic. Patients come to your doctor, I can't eat anything, I can't drink anything. The minute I eat or drink, it comes up. Do something, operate. I'm the worst patient you'll ever meet. I'm hopeless. No. This is not gastroparesis. This requires a history. And a key part of the history is that within minutes of eating, as in a belching syndrome, I can belch. And part of belching is bringing up the food. And that is rumination syndrome. So I want to be very clear that, I'm treating gastroparesis. That's okay. I can live with that. But if you've evolved to rumination with gastroparesis and you're hiding it by just venting quickly after you eat, that's not going to be a long-term solution to anything. Rumination is not treated by venting. Rumination is treated by meditation, breathing, virtual reality, tapes, the whole 9 yards, hypnosis. So I'd have to be very clear that venting is just not an excuse to get through the day. There may be some cases of extra gas, but if you basically are doing TPN at night, and if you're doing some peg tube feeding during the day, and maybe you're taking antibiotics for your SIBO or your small bowel bacterial overgrowth, I'm just not clear on where this gas is coming from. It doesn't just come out of the blue. Something has to make the gas. And most of these people on PPIs, and the gas comes from the small bowel because they're achlorhydric, and the small bowel has SIBO. But venting can be simply a disguise for the fact that when I eat or drink, I can't keep it down. I've got to bring it up. That's not acceptable. That's rumination, and it needs to be diagnosed separately and treated separately. That's my concern.
Richard,
Thank you. Go ahead.
manometer to confirm rumination.
Whoops, we can't hear you.
How often you do esophageal manometry to confirm? Because a lot of patients, sometimes the adolescents and the families, I agree with Richard, it's a very common, the supragastric belching syndrome and rumination. It's a terrible problem. They woke up with the basin, it's speeding up. So sometimes you have to do, you can make diagnosis with the antrodenal of the esophageal manometry. But sometimes I found, in our experience that you have to show them doing the manometry what happened, the physiology with the otherwise they don't buy it. They say, when are you going to treat me? You're going to treat me with tapes.
I agree. Yeah, you can do an impedance test. You can do an impedance test. It does require the patient to swallow a small tube, but it takes about 30 minutes. You can give them a glass of water, and you can show the parents that pressure builds in the abdomen, the LES, the lower esophageal sphincter opens, and something comes up, and there's contractions in the stomach below it. So you can demonstrate that if there's some skeptical people around, or you can say, let's start trying the treatment, including tricyclics. This is a brain-gut phenomenon. This is the feeling that you can't tolerate any distension or any pressure in your abdomen. So we use a lot of tricyclics, and we use the relaxation methodology. But you can do the impedance. Yeah, we do it, but it's only for skeptical people.
Thank you for that answer. And now there are a lot of patients who seek alternative therapies, either in conjunction what they're doing with the medical, or just because they're not getting any assistance with the medical. So you mentioned hypnosis. What about acupuncture and some of the other alternatives that may be an option to work in conjunction, or just to help with symptoms that aren't being managed? And I'm going to open that up to anyone who would like to answer.
I'll just say a few things. I don't stand in the way of patients doing anything. So it's not a good idea to critique. We live on the border. So I have patients whose grandparents in Mexico gave them anything growing up. And they go back to that when they have times of need. So we don't stand in the way. Acupuncture's only problem is it's 1 or 2 hours a week. And you've got a problem that's 24/7. So acupuncture it's good that day for arthritis. It's good that day for migraine. But we're talking chronic nausea and trouble every day from the stomach. And it's unlikely that the hangover effect lasts very long. But we do not stand in the way. We encourage them to use it, but also use our treatment. It's not instead of, it's in addition to. I'll let the rest of the colleagues have their comment.
Agree with the instead of, but in, along adjacent. I mean, I always think about risk versus benefits, and a lot of the therapies that patients try are safe, and so as long as they like, I really appreciate having an open dialogue with them and them telling me what they're thinking of trying. If it's the weird unlabeled Mexican drug that they don't know what's inside it, obviously that's not safe. Certainly in my practice, while I do use medications to help manage their nausea, they can try ginger, they can use aromatherapy. Certainly there's other things, and so I do let them know, and I do always try to learn from my patients other things that they've tried that have helped. So if there's a motion sickness element, certainly they can try a motion sickness band. Generally with those therapies, I think, for instance, like aromatherapy, I don't tell them to invest in a giant diffuser, but if they have a lot of morning nausea, then they can potentially smell rubbing alcohol. They can try ginger oil, lavender oil, peppermint oil, just on their wrist points. If it works, then they can use it. So certainly, as we have very limited medications for nausea, and they have adverse effects aside that, I think using these is great. So I do add and advocate, and I have a kind of a nausea list of things that patients can try.
Thank you. Another patient says, I have seen more and more from other idiopathic gastroparesis patients experience hypoglycemia. I also deal with pretty dangerous hypoglycemia episodes. Why is this becoming a more known issue within the GP community? I rarely ever see it discussed as a potential issue or even acknowledged. Whoever would like to answer that.
So this is idiopathic gastroparesis patients who are documenting episodes of hypoglycemia.
Correct.
Well, number one, I'd go back and make sure we do have the right gastric emptying study. I mean, symptoms of dumping syndrome are very similar to gastroparesis, almost identical, apart from diarrhea, which is often common after meals with dumping. So I would recheck the criteria that was used to document or make the diagnosis of gastroparesis. And then number two, I guess we'd be very clear that, are they fasting or doing unusual things during the day regarding their hypoglycemia? And, we might double check their adrenal status. There's always a subgroup of people that have failure of adrenal glands, etc., with or without diabetes. So I'd be a bit, I'll be a little bit skeptical. Make sure we know what other medicines they're taking. That'd be my take. I'm sure Alex sees some of this in the pediatric world as well.
Yeah, I think I agree with Richard in that, but I see it in patients with mitochondrial disorders. I see hypoglycemia more than in the regular, idiopathic gastroparesis was fundoplication. We don't do fundoplication anymore, but maybe 10, 15 years ago, I used to see more. But again, that is a mixed bag, because then I think you introduce the fundic sequestration and the rapid empty, so I think it's probably dominant rather than gastroparesis. So we try to avoid that these days, but I think the gastric emptying help us in that situation.
Thank you.
And
Yes, hello.
Maryangela, I see
Yes.
Dr. Mashimo
I was just going to welcome him. It's so good to see you.
I'm so sorry.
He's
No,
dying
I'm
to
so
answer
sorry.
questions.
It's been one of those days, but and great to see the panelists' familiar faces, Professor McCallum and Dr. Flores. It's great to be seeing people that we've collaborated along with, Maria. But anyway, so just a quick bit is that, of course, gastric emptying is generally of food, and so, or digestibles on the scrambled egg. So we're routinely not measuring liquid emptying And this is one of the issues with sometimes early diabetes, where we have lack of fundic accommodation, therefore a high pressure system that ends up in a fast or if not dumping syndrome, particularly of liquids. And so this is something that we're underappreciating, but from the consortium study, we're finding that it's not as the diabetes progresses, we see a greater variability, not necessarily slowing down of stomach emptying, but a greater variability in the emptying setting. And I suspect part of that is because since we don't distinguish the liquid from the solid emptying, and the quality of the stomach emptying, the food emptying, is highly dependent upon how well you congeal or mix that scintillant together with the food. If it's leaching off, or your scrambled egg is kind of leaky, you're actually looking at a lot of liquid emptying. And so this is one of the issues. And for a patient who doesn't have established diabetes, I would fully agree with Dr. McCallum that an endocrine workup is necessary, even ruling out things such as an insulinoma. So those are just my 2 cents.
Thank you.
The other thing that just to mention is the reactive hypoglycemia, especially in those patients, they're infants, they're in formula feedings, because those ones you have to do liquid emptying. And in our lab, the T150, the T50 is 50%, after an hour, you give it, a formula. Again, which type of formula depends on that. And now with the use of blenderized formulas, that has changed. And there's no new data, in terms of radiopharmaceuticals finding that. So we still go by the milk type of mixture or the blenderized.
Thank you. And we have a question here. I find, in addition to feeding triggering symptoms, physically engaging my core muscles, even through basic stretching or light exercise, immediately causes full stomach distension, painful GI spasms, and eventually vomiting. Have any of you seen this pattern in your patients? Whoever would like to respond.
Well, we need to be very clear about the baseline pain. Okay, there's a syndrome that's, again, epidemic, called Carnet's sign. Carnet's sign is present in everyone who ruminates. And then if you vomit regularly, you contract your rectus muscles, and those muscles get very tight. They do 100 push-ups a day, and they're painful. And so Carnet's sign is prevalent. Now, if you lift something or do something or move and involve that's pain. That's one component. Now, as far as gas and bloating, I don't know whether you make Carnet's sign worse, but obviously gas and bloating has its own world of unacceptable distension and discomfort. So we got to be careful we don't mix that up. The distension pain of gas and bloating obviously is different from vomiting, but the vomiting muscles can become very sore, and we often use lidocaine patches, heating pads. This can be a very stressful thing for the patient.
Thank you.
I think maybe just to mention the Carnet's sign as part of the symptomatology in patients with AGNES, that you're familiar with, anterior cutaneous nerve entrapment syndrome. Those are patients that really, that's what we use in the pediatric population, or patients who have intervention in the abdominal wall. And those patients usually get a nerve block, but I think I said in kids that they're distended, I don't think you can elicit the Carnet's sign because they're so bloated, So I think for us, it's in the criteria when we're going to diagnose AGNES and then decide if he's going to need a block, lidocaine, like Dr. McCallum mentioned. So, and that's one of the things that we use as a guide. Has to be a little older kid, to cooperate with exam, but this is a real entity, I think. I don't go as far as sometimes they need abdominal wall surgery, to relieve the nerve entrapment, but I think the blocks is the way to start. First with the lidocaine patch, and then with the block, nerve block.
This is Hiroshi. In the adult population, though, I would have to add that those that, worsen with some kind of strenuous exercise or increase in abdominal pressure, we have to think about a covert inguinal or femoral hernia, a covert, let's say, paraesophageal hernia that could be hard to localize. This is where the endoscopist can come in handy, because we're at a privileged time as an endoscopist to be able to truly bloat up the stomach more than a radiologist can do with their Valsalva maneuvers. And so by totally bloating up the stomach in a retroflex position, we can actually elicit both sliding hilar hernias and the paraesophageal hernias. A good examination for inguinal or femoral hernias, or even the rarer Spigelian, is certainly worthwhile. I have to agree with Dr. McCallum that some of these rectus muscle tears from strenuous activity can certainly lead to the Carnet's sign.
Thank you. What is the difference between POP and POEM where the pylorus is concerned? Is one better than the other? Whoever would like to answer.
What was the question again?
What is the difference between POP, P-O-P, and POEM, P-O-E-M, where the pylorus is concerned? Is one better than the other?
Tom, you haven't said much. Why don't you give us the philosophy from Louisville?
Yeah, I don't, it depends. For pyloric therapies, you can do it endoscopically with pleural myotomy or GPOM. You can also do it laparoscopically. It can be done openly. Each one's a little bit different. There's a tremendous amount of literature now coming out on pyloric therapies, but I've not seen a head-to-head comparison, although I may have missed it, between so-called POP and GPOM. There may be in the future, because there are a couple of centers that have now got randomized studies going that do primarily POP. And there eventually will be randomized studies with GPOM. The standard pyloric therapies laparoscopically and open have been done longer, so there is more data. But they're different. But I don't know at this point that I could recommend one over another. It's a question of given center's experience and comfort level with what to do for a patient.
Yeah, I think GPOM, as Tom said, this is still evolving. I mean, all endoscopists who get into this are somewhat have a cowboy mentality, see one and do one. And quite frankly, I'm not going to go to that endoscopist for quite a while. We don't know how much of the pylorus is individually cut every day on a GPOM. You may have a good day, and you may not. Your fear is perforation. There's always trepidation. How far into the duodenum do I go? This is still technically work in progress. The pyloroplasty has been around since the arc. Surgeons can cut the pylorus. There's no question about that. They do a Michalitz pyloroplasty, do a double suturing technique, close the pyloroplasty. I see one every day when we do our patients. And so, it's guaranteed. And we see half or 2/3 of those patients have a normal gastric emptying post-surgical pyloroplasty because the pylorus is cut. In GPOM, it's still evolving. How much is cut? It could depend on the expertise of the endoscopist and his nerve power as to whether he wants to push the envelope and risk a perforation. Surgeon doesn't have that concern. So I think GPOM, although it sounds good, you can be home that night, no problem. It's not there. It's not there. GPOM is work in progress, and it's going to take a lot of reassurance that it's worthy. So I think that's where we stand. That's where I stand on that.
Thank you for that information. We're short on time here. We've gone a little over, but I just want to thank all of you for participating in this panel and for being here. And I would be remiss if I just didn't say a quick happy birthday to Dr. Mashimo. Today's his birthday.
It's just
And-
50.
And this is Joan, and I want to wish Dr. Mashimo, thank you for serving us on your birthday. That's exciting and very committed, I have to say. I want to thank, what a group of people with expertise, including one woman, this is good, to join us today, honestly. We could go on and on and on for hours. Thank you so much. And Maryangela, thank you so much for facilitating a wonderful session. I think we can end this with a huge to be continued. Agreed?
It was really nice to see
Great.
everybody. We're looking younger every day. Richard, nice to see you. And Tom,
Good seeing you, Alex.
Hiroshi, stay well.
Later.
Thank you.
Thank you very much for the
Thanks,
invitation.
Tom.
Thanks.
Thank you. Take care.
Thank you.
Bye-bye.
Bye.